Hello, and thank you very much for joining us at the current Digestive Health and Surgical Institute lecture series. I'm Miriam Kasha, your host, and tonight we'll be talking to Dr. Marcus Ahito, a gastroenterologist from Advent Health East Campus, and Dr. Yafa Tilahoon, a surgeon from our East Campus as well. Tonight we'll be talking about medical and surgical approaches to constipation. At the bottom of our lectures, you'll see a phone number where you can text any questions that we'll be happy to answer at the end of our presentation. Dr. Ahito.
All right, so I want to talk about evaluation and management of constipation. So before we talk about constipation, it's always important to first, before we talk about what's abnormal, is to determine what is normal, okay? So normal in terms of frequency is anywhere between 3 bowel movements a day to 3 bowel movements a week. And in terms of consistency, we use this chart called the Bristol Stool Scale, okay? And this scale is actually very important because it gives us an idea in terms of the stool consistency of patients. So a normal stool consistency can be anywhere between a type 3, 4, or 5. Patients would describe their stools as sausage shape or such as like having chicken nuggets as a stool consistency, okay? And this is important because a lot of times stool consistency based on the Bristol Stool Scale actually correlates with colonic motility. So if you have a patient who comes in with sausage-shaped stools, it's most likely they have normal transit time. We also use the Rome criteria for functional constipation. This requires at least 2 of the following symptoms with chronicity, meaning them having these symptoms for at least 3 months. And those symptoms include having hard stools, straining, incomplete evacuation, sensation of blocked defecation, manual maneuvers such as manual disimpaction, digital disimpaction, or vaginal splinting to facilitate defecation, and having less than 3 bowel movements per week. And patients should not have loose stools or diarrhea. And we should also exclude patients who have fulfilled the criteria for IBS. So when we talk about IBS, although patients with functional constipation may have some abdominal pain, it should not be their predominant symptom. Otherwise, you may want to consider them as having IBS or irritable bowel. This is a very important chart, and the reason I say that is because when patients with constipation come with us, a lot of times we ask them how many bowel movements they have. These questions pertain or focus more on colonic transit. However, looking at this chart, you'll notice that majority of the patients who come in with constipation actually care less about their frequency in bowel movement. They care more about bloating symptoms. So bloating is a very nonspecific symptom. And yes, you see this in patients with constipation. However, you see this in different types of gastrointestinal disease, such as celiac disease, food intolerances, and many more. So this is important to know that when you first see patients who present with constipation, it's important to ask them what their most bothersome symptom is. Because if we focus on stool consistency alone or stool frequency, we're missing the big picture, okay? And knowing this and knowing what their predominant symptoms are helps us guide and helps us determine or define our treatment goals for these patients. Okay, I will talk about types of constipation. First, before we go over the primary causes, it's important to check for secondary causes of constipation, such as whether patients have medical conditions or on certain medications that can make them constipated. Okay, and we'll go over this later on as we go through our presentation. Primary causes of constipation include slow transit constipation. A lot of times, these patients would present with bloating, okay? And they really lack, a lot of times they lack the urgency or sensation to defecate, okay? This is a problem where stool does not travel or travel slowly from point A to point B, okay? Then we have the obstructive constipation, okay? So stool travels from point A to point B in the colon, but patients have difficulty expelling stool. They may have a structural abnormality that causes them to have obstructive constipation, or they may also have dysenergic defecation, okay? So a lot of times these patients have that sense of urgency but have difficulty in expelling stool, okay? And then we come to normal transit constipation, which is probably one of the most difficult types of constipation. This is where patients have normal transit, but they still present with symptoms. And this is really synonymous with IBS-C and patients with visceral hypersensitivity. So, how do we approach chronic constipation? First, it's important to take a comprehensive interview and physical exam. At this point, it's important to identify what the secondary causes of constipation are. Does the patient have any medical condition? Is the patient paralyzed, paraplegic? Does the patient have any Parkinson's, endocrinopathies, or neurologic disorders? Or does the patient take any medications, such as iron, okay, or constipating medications such as opioids or anticholinergics, okay? And with physical exam, it's important to not just do an abdominal exam, but also a rectal exam. With the rectal exam, we'll be able to identify whether the patient has good rectal sensation, okay? The patient has any type of rectal prolapse or any anorectal disorders preventing them from passing stool. Once we identify any of the secondary factors, then we may consider further workup, which may include metabolic or structural evaluation, okay? So if we identify a patient or we suspect a patient may have thyroid disorder or Parkinson's disease or some type of electrolyte imbalance, then I will usually tailor my workup towards that history, okay? Also, I also like to ask patients and identify whether patients present with red flags, okay? This include elderly patients who present with gastrointestinal bleeding, weight loss, maybe they have some anemia, okay? Or maybe they feel like there's a mass in their rectum, okay? So for these patients, I would order for a colonoscopy. So colonoscopy is not routine for evaluation of constipation, okay? But if you do have any indication to perform a colonoscopy, then that would be the time I would order for one and proceed with colonoscopy. Then we go to a therapeutic trial, okay? When we talk about a therapeutic trial, first I always ask patients whether they eat enough fiber. Do they eat adequate amount of fibers? The recommended amount of fiber is 25 to 30 grams of fiber per day. And whenever I have patients on fiber, I also make sure that they drink adequate amount of fluids, okay? I also inform patients that when they increase up on their fiber, they may also experience bloating in the future. Because a lot of times their stool consistency may improve with the fiber, but then they'll come back to you saying that they're extremely bloated and distended. So I usually give them a heads up and tell them that fiber may also cause some bloating, some discomfort, and occasionally some abdominal pain, okay? Then we do some hyperosmolar laxatives. These include the over-the-counter laxatives we see at our local grocery or pharmacy. This could be magnesium, Miralax, or lactulose, okay? These are non-digested, non-absorbed, and these do not cause electrolyte imbalances, okay? They do soften the stool and they may improve frequency of constipation. However, these agents do not improve abdominal pain. So I also tell these patients that as to set their expectations. Stimulant laxatives such as bisacodyl and senna are stimulants. They stimulate secretion and motility of the small bowel and colon. And again, these agents do not improve symptoms of IBS, okay, but they do help with motility or stool frequency. However, a lot of times these stimulant laxatives are very unpredictable, okay? And sometimes they cause electrolyte imbalances. After a trial of laxatives and after making sure a patient consumes adequate amount of fiber and fluids, we assess their response, I would say probably 2 or 3 weeks afterwards. And if they have good response, then good. If they have inadequate response, then we proceed with anorectal manometry. Okay? This is a recommendation by our society. And the problem with anorectal manometry is that it's not readily available in other institutions. However, Advent Health has this. Okay? So the reason we proceed with anorectal manometry is because we want to evaluate patients for defecatory disorders first, before we consider them for any colonic transit dysfunction. So anorectal manometry is a functional test. It helps assess the sphincter function. It helps assess anal sphincter pressures, rectal sensation and compliance, any reflexive response, relaxation. It helps assess response to biofeedback therapy, which is one of the mainstay therapies for dyssynergic defecation. And in our institution, we use the 3D topography probe, which consists of 256 electrodes, which helps measure the pressures in the anorectum and gives us a good idea about the pressure points in the anorectum. Okay. If the anorectal manometry is inconclusive, then we can proceed with defecography. This helps us assess the anatomical and functional changes of the anorectum. These are best for looking for enteroceles, intussusception, prolapse, rectoceles, and pelvic floor descent. It also assesses for anorectal angle at rest and during expulsion of barium. So since we've been talking a lot about dyssynergic defecation, I want to talk a little bit more about dyssynergic defecation. Basically, what this means is patients have ineffective defecation. Okay? These patients meet the criteria for functional constipation, so they would present with difficulty expelling stool and infrequent bowel movements and so on. The manometric criteria is that these patients may have paradoxical increase in anal sphincter pressure. They may have poor relaxation of the anal sphincter and also inadequate propulsive forces noted on manometry. Okay? In addition, these patients also are unable to expel balloon during anorectal manometry. If anorectal manometry is not performed, you can also identify this in patients who have retained markers during the SITS marker test, okay, or patients who fail to evacuate barium during standard defecography. All right. Biofeedback therapy is a technique of conditioning and retraining the mind and body to normalize bowel movements. This is performed by our physical therapists specialized in pelvic floor therapies. The goal of biofeedback therapy is to teach diaphragmatic breathing exercises, teach anal sphincter and pelvic floor relaxation, improve rectal sensation, eliminate sensory delay, and improve recto-anal coordination. So biofeedback therapy is the treatment of choice in patients with dyssynergic defecation. If the anorectal manometry is normal, then only then we'll proceed to colonic transit testing. Okay? This will help us identify whether the patient has slow or normal transit, colonic transit. Tests we offer in our institution, we have the SITS marker and the wireless motility capsule. A SITS marker is a test that where a patient swallows a capsule consisting of multiple small radio-opaque markers, and then our protocol is to get an X-ray after 5 days. After 5 days, if these markers are completely expelled from the colon, then the patient has a normal test, okay, and most likely has normal transit time. We also identify whether the markers are spread throughout the colon, which may indicate slow transit constipation, or whether they all compile around the sigmoid or rectum area, which may be suggestive but not consistent for anorectal disorder. We also have the wireless motility capsule. This test involves a patient swallowing a capsule, and the advantage of this test is that it measures the whole gut transit time. It also gives us an idea about gastric emptying, small bowel motility, and colonic motility as well. The downside to wireless motility capsule is that it's very expensive and not readily available. So moving on to approach to normal and slow transit constipation. So after a patient has tried numerous over-the-counter laxatives, they're bulked up on fiber and they drink plenty of fluids, then we may consider newer pharmacologic agents. So the common ones we use may include lubiprostone, we have linaclotide, and prucalopride. Okay, these are prescription laxatives. Okay, and for the most part, these laxatives promote and help spontaneous bowel movements. Okay, so as noted, they do help for some patients improve the frequency of their bowel movements. However, not all of these laxatives improve global symptoms such as abdominal pain or bloating. Lubiprostone has been shown to improve with bloating and straining, and also with stool consistency. Now, Motegrity, on the other hand, okay, has the advantage of working also for patients with gastroparesis. The downside with Motegrity is that it should be avoided in patients who may have suicidal ideations. Okay, so if there's no improvement with these pharmacologic agents, okay, we can sometimes repeat colonic transit testing with the medications and see whether or not they improve. Okay. If there is some improvement, if there is no improvement with their colonic transit testing, then sometimes we may consider getting a gastric emptying study. And the reason is we also want to assess for generalized dysmotility disorders. A lot of times these patients may present with constipation, but they may also have underlying gastroparesis or even small bowel dysmotility. Okay. If they do have slow transit or if they do have gastroparesis, then we treat them as such. Okay. If the studies are normal, then we may consider referring patients for colonic manometry or barostat therapy, okay, and eventually referral to colorectal surgery for consideration for surgical treatment. All right. So in summary, we talked about defining constipation and going over the types of constipation, the causes of constipation, diagnostic approach, and treatment options. All right. At Advent Health, I'm proud to say that we have a very dedicated multidisciplinary team consisting of specialists, okay? And we have diagnostic resources such as MR-Def echographies, we have top-of-the-line manometry, 3D high-resolution anorectal manometry, colonic transit testing, including the wireless motility capsule if we're considering any patients with generalized dysmotility disorders. And we also have specialists and physical therapists who perform pelvic floor retraining and biofeedback therapy.
Thank you so much, Dr. Ahido, for that very thorough discussion on medical approach for constipation and highlighting all the things that we at Advent Health have available as part of our many resources. Now, Dr. Yafet Talahoun is going to tell us about the surgical approaches to constipation.
All right. So, thank you for that wonderful summary, because I think, the key to the surgical management is really sort of having a multidisciplinary approach, and sort of the wide range communication and education of the patients is extremely critical in making sure that they have the most optimal outcome in the long run. Patients that come for surgical evaluation usually either come after thorough GI workup and proper management, or sometimes they come to the surgeon straight from the primary care physicians, or even just they refer themselves and walk into our offices. So it's sort of what Dr. Aguido just said, a very detailed stool history or very detailed history needs to be taken up front. And sometimes these can take up to an hour if we're supposed to get appropriate history. Most of the time, for me personally, I usually like to get a good stool history, and if they can't give me a good stool history, we'll ask them to keep a diary of their bowel habits with a short follow-up, so that we have a better understanding of what their habits are really like. A thorough understanding of what their day-to-day dietary intake is, fluid intake, their exercise habits, and especially sort of what we talked about, what is really about their constipation that concerns them. Majority of them, usually the main concern is bloating. There's some abdominal pain, sometimes straining and inability to sort of evacuate the stool from the rectum. And again, maneuvers that patients will do, either splinting in the perineum or using manual disimpaction maneuvers. Detailed medical history is absolutely critical. Both past medical history, medications patients have been on and off over the years. Over-the-counter medications sometimes play a big role, and patients sometimes fail to mention those to us. Psychiatric history is extremely important. A lot of the psychiatric medications play a role, or have a cause constipation as such. We have to understand how long they've been on it, and if there was a recent medication change, how much did that influence their new symptoms of worsening constipation. Surgical history, any abdominal surgeries they've had, if they had any endocrine surgeries as well, such as having their thyroids removed, parathyroids removed, and things as such. You have to sort of discuss with patients medication history, but the most important one for surgical management is also you have to be able to build a good enough relationship when you're meeting patients with constipation that you have to earn their trust to ask about abuse. And this could be both emotional, sexual, physical abuse that they may have had years ago. But later in life, or even at the time of abuse, this may present itself as severe constipation. And the reason this is so important is because for a lot of the research that has shown patient satisfaction after surgery, patients who have a history of abuse tend to have the worst outcomes in terms of patient satisfaction. The physical exam in most of these individuals is usually benign and normal with very few findings. Some patients may have a little bit of abdominal distension, rarely abdominal pain. If the patient has never been seen by a physician, sometimes you'll be surprised and feel a mass if there's an obstructing lesion there causing their constipation. For us in colorectal surgery, we obviously focus a lot on the anorectal examination. Evaluation of the sphincter function is important. As part of the examination with digital rectal examination, we ask patients to squeeze or relax, assessing the resting tone, squeeze tone, and then also Valsalva with rectal examination to see if they have paradoxical movement. And this gives us lots of information. This gives us, right off the bat, you will know if the patient needs to be referred to physical therapy just based on that examination, to at least start the process to help them understand how their mechanics work in terms of defecation. I always do an anoscopy to look within the rectum. A lot of times while doing an anoscopy, you can see the rectal mucosa fall into the scope, which will give you an idea of if they have sort of rectal intussusception as well. And obviously, as part of the history, you will assess if they have any prolapsing tissue from the rectum, if rectal prolapse is part of the reason they're having defectory obstruction. And if they have any history of those, usually I'll ask them to Valsalva on the commode, and then we'll assess if there's any prolapsing tissue from the perineum, both from the rectum and vagina. So the workup, labs are should be ordered, especially if sort of we're marching as part of the initial workup if they haven't had one recently, or if they are not actively following with a primary care physician that monitors it. a basic CBC metabolic panel, ensuring that you pay attention to their calcium levels, thyroid function test, assess for diabetes as well. For us, we always ask for colonoscopy, especially even if they're not of screening age. Any change in their stool habits requires that we rule out any mechanical obstruction. Sometimes this may not be a malignancy, but sort of subclinical diverticular attacks may cause a narrowing in the sigmoid colon that may play a role in their change in their stool habits. So just understanding what their anatomy is like is quite critical in terms of long-term planning for surgery. And obviously, like Dr. Aguido said, usually you will assess or consider doing colonic transit studies. And I agree with Dr. Aguido that usually I'll never order any colonic studies until we exhaust all medical management. And this is sort of down the line as you're working with patients a few months in, that I usually would then initiate the workup with radiopaque markers or scintigraphy and capsule study. And the scintigraphy is mainly to look at the global GI motility for us if the capsule study is not available or the patient can't have access to it. And obviously MR defecography will be part of that workup as well, along with anal manometry, which I forgot to include in this slide. So once the patient, usually let's say if Dr. Aguido had seen the patient and he's done an exhaustive workup and the patient is diagnosed with slow transit constipation, and they've gone through all the medications, they come to us with a diagnosis of slow transit constipation. And I think me as a surgeon, if all the work has already been done, even though they've gone through extensive medical management, I do my best to use that initial conversation to educate them about what it means to have surgery and setting the patient expectation appropriately. Because if the biggest concern for the patient is abdominal bloating, that may not resolve by just surgical approach for the surgical treatment of the constipation. And having them understand the type of surgery that they will potentially be facing, whether if it's, for example, for slow transit constipation, it would be removing their whole colon and creating an ileorectal anastomosis. And once they understand how big of an operation that is and what that may mean in the long term and associated complications, a lot of times patients are willing to go back and try things that they thought they didn't want to try. You know, for example, they may have said, "Hey, Dr. Aguido, I don't like the way Miralax tastes. I'm not going to do it." But the minute they realize that the surgical option is not as simple or straightforward as they may have perceived, at that point, patients sometimes are willing to go back and try things for a little bit longer period and actually give it a shot. So sometimes the role of conversation with the surgeon in sort of highlighting all the different paths, what could happen if surgical management is pursued, gives the patients a little bit of a different perspective and allow them to go back and maybe try some of the medications, some of the bulking agents that they never really gave it a true shot at. And so we always, even though the diagnosis and the workup was done by our gastroenterology colleagues, we always kind of send them back out and say, you know, it doesn't sound like maybe you gave the bulking agents, fibers, a good shot. Can we try that one more time? And this sort of allows them to have another thought process as well. Think about, you know, allow the patient to have time, speak with their family members and things like that to see if they really want to go through with surgical intervention. So again, the slow transit constipation, you always want to see that before you offer any surgical intervention. And what you're looking for mainly is, like Dr. Aguido said, is sort of an even distribution of the markers. And you have to have about 80% of the markers to evacuated to call it a normal study. But if you have more than 20% retained, then it's an abnormal study with diagnosis of inertia. For me personally, I always like to get scintigraphy or capsule study done because we have to understand what the remainder of the GI motility is like before we do any surgery. Because if we just proceed with the SITS marker study for surgery, they may still continue to have the symptoms of abdominal distension, bloating, and pain when you add the fact that there's pain that's going to come with surgical intervention as well. So we may make their overall symptoms worse and worse, and they may not be happy with their overall outcome. So for slow transit constipation, the mainstay surgical intervention is abdominal colectomy with ileorectal anastomosis. In the past, segmental colectomies of different parts of the colon have been attempted, but it's nearly 100% recurrence rate of symptoms, and patients require further additional surgical intervention. The proctocolectomy with the ileal pouch anal anastomosis, not widely practiced, only in small case series. obviously the results would be similar to what FAP patients would have. Ileostomy, I think, is a very important option because ultimately if continuity of bowel function can't be ensured, patients have to understand that the possibility of an end ileostomy or having a permanent ileostomy is potentially could be part of their treatment. And a lot of times for us, for patients who really we're worried that they won't be happy with a major operation of removing their colon, creating a diverting loop ileostomy becomes a very valuable tool for the surgeon. And it allows the patient to understand, to see if their symptoms improve with a loop ileostomy. Because at that point, then you remove the function of the colon to see if, is the constipation really the thing that's causing them their symptoms? Is that bloating, the abdominal discomfort, the not being able to eat what they want to eat? Those things, is that really related to sort of the colonic inertia, or is there something more to it? And it allows the patients to sort of see what it also means to have an ileostomy in place, because if we go through with the abdominal colectomy and the ileorectal anastomosis and they're not happy with the function, our only alternative is an ileostomy. And so that initial consultation, I personally would always introduce these topics to them to allow them to know that, the concept of having a bag is part of the equation. A lot of times will sort of trigger the patient to say, maybe I should give that Miralax one more shot. Antegrade colonic enemas, mostly done in young children and not really widely used in the adult population. And primarily the problem with that is complications or morbidity of maintaining the access for antegrade colonic enemas. And these can be infected, you can have skin infections associated with them, you can have the access can close off, and a lot of times patients can struggle and have a significant morbidity. Sacral nerve stimulation has been shown to increase number and frequency of bowel habits. However, this is still sort of in the initial phase where it's not widely accepted, and currently in the US it's not approved for use yet. But under clinical trials it may be available in certain places. For me personally, I approach the total colectomy laparoscopically. I use usually a 4 trocard or 5 trocard, 5 millimeters to be able to do the total colectomy, and then usually extract the specimen through a small fan and steel incision. And it also depends on the patient's body habitus in terms of the surgical approach. And most patients usually do very well during the operation. It's a pretty standard operation from the surgical perspective. The reported number for clinical improvement for patients, whether that be number of bowel movements they're having, and their ability to evacuate their stools, or their symptoms of bloating, distension, or the sort of discomfort that they were experiencing before, will improve in any range of between 50 to 100%. And these numbers are coming from small case series or prospective data that are kept in different areas, and randomized clinical trials are hard to come by because the number of patients that actually undergo these resections is not a lot. Segmental resections, like I said earlier, clinical failure rates is almost 100%, so we don't offer it in terms of as a surgical alternative. The one thing patients have to realize is that the ileorectal anastomosis, connecting the ileum to the rectum, has the highest leak rate in our surgical literature when we're creating continuity, bowel continuity, and that approaches anywhere from up to 11%. And so in these individuals, they have to know that the perioperative risk of an anastomotic leak and infection and things like that are the highest we have in colorectal surgery. And as such, there's always a chance that they may end up with a temporary ileostomy or even a permanent ileostomy, depending on the level of anastomotic breakdown. Very common to have bowel obstructions postoperatively. These days with laparoscopic approach, that number sort of approaches more 8%. But if the operation is done open or they've had previous other surgeries, then postoperative or sort of over their lifetime, patients can have multiple bowel obstructions and then require multiple hospitalizations and even further more surgeries. So patients need to be aware of these things before undergoing a surgical intervention. One thing that always stands out for patients who undergo abdominal colectomy with ileorectal anastomosis is that a good number of patients will have a significant postoperative ileus. And this can be quite distressing to patients because once they have their colons removed, they sort of almost expect that automatically they're going to be going to the bathroom frequently, that's not going to be a worry for them. But sometimes we end up in situations where they're just not passing anything from below. They have significant abdominal distension, nausea, vomiting, potentially require a nasogastric tube, decompression of the stomach, and in this may end up being a prolonged hospital stay in the initial postoperative period. And these are all sort of reported nationwide in most studies that have been done. Overall, the outcome from total abdominal colectomy and ileorectal anastomosis can be variable. Overall, the constipation will improve. Patients will have more bowel movements. However, they may develop new symptoms that they didn't have before. Abdominal pain is reported in 41% of patients that may not have had it before surgery. Bloating in up to 65% of patients may persist after an operation and may not resolve. And bowel movement assistance, whether in 29% of patients with additional laxatives or other agents, and incontinence to gas or liquid stools reported in up to 47% of patients in most studies. But even with all these new symptoms that may arise, the most patients though still endorse that they would still choose to undergo a total abdominal colectomy with ileorectal anastomosis when it's done to the right patient for slow transit constipation. This is a study that came out in 2020, and this was a 15-year median follow-up for patients who underwent subtotal colectomy with specifically ileorectal anastomosis. They started off with 102 patients, but they were able to get follow-up surveys done on 42 patients. And the mean time from surgery to the survey was about 15.9 years, and the range anywhere from 1.7 to 29.7 years, with a mean age of at surgery being 46. And the preoperative diagnosis for slow transit constipation was made by scintigraphy and radiopaque markers. And what's interesting in this study is that 50% had less than 4 bowel movements per day, which they were pretty happy about. The most common Bristol stool score was a 6, so it's not in that normal range between 3 and 5. And the mean St. Mark's continence score was 7.45, but the St. Mark's continence score went up as the Bristol stool score went up as well. So as you can see, the St. Mark's continence score is high for the individuals, for example, who have a Bristol stool scale of 7. 21% had severe incontinence and satisfaction severe incontinence, but a lot of those patients were also much older, and most of them were women. But even with these results, the satisfaction and likelihood of the patients to choose to undergo this operation again on a scale of 1 to 10 was rated at 10 out of 10 with all the patients that were resurveyed after all these years. So the study also shared that they had a longitudinal data where they had 15 patients that were actually initially surveyed in 1995, and they did the follow-up survey in 2018. And in those patients, overall the frequency went down in terms of number of bowel movements they had, but then the stool consistency was over the years was becoming looser, so they were having to use adjunct agents such as Imodium or other bulking agents to thicken it up. And there is deterioration of continence. This was very difficult to determine because majority of the patients are women, and they've had vaginal births and some with injuries as well to the sphincters when with childbearing. So in that sense, that the role of incontinence and how it directly relates to the total abdominal colectomy with the ileorectal anastomosis, that's a little bit more difficult to decipher. But even in this setting, even in the setting where patients were having incontinence, they still would elect to undergo the procedure again after all these years. This is sort of all the studies that have been published in terms of patient outcomes for ileorectal anastomosis. I apologize, it's hard to see, but all the way on the right side you can see the patient satisfaction or success percentage ranges from anywhere from 100% to the lowest one as reported at 50%. And in this chart here, the longest follow-up, as you can see, is 10 years, and the patient satisfaction at that point was 77%. So overall take home from the surgical treatment of slow transit constipation is that the surgical intervention of choice for slow transit constipation is total abdominal colectomy with ileorectal anastomosis. Long-term patient satisfaction is high with majority of patients who are willing to they're willing to undergo the procedure again. But the key to this is that patient selection is extremely important, and allowing and patients need to understand what they should expect, because setting the patient expectations is absolutely critical, because a lot of times they may undergo the operation, but if they know that, for example, if the bloating was the one thing that bothered them the most, that may not resolve after the operation. What will resolve is the number of bowel movements they'll have and their ability to evacuate their stool, but it may not get rid of the abdominal distension and discomfort that brought them in to begin with. So slow transit constipation, that's associated with pelvic outlet dysfunction. These are very tricky to manage, but the best approach is actually to treat the outlet dysfunction first prior to offering patients any surgical intervention. So like Dr. Guido mentioned, getting them to the physical therapist as early as possible, the pelvic floor physical therapist as early as possible, to get them to do the biofeedback, get them to work on things at home to improve their ability to defecate. That's extremely important. And then for patients who undergo total abdominal colectomy with ileorectal anastomosis, prior to treating the outlet dysfunction, usually leads to higher rates of recurrence of constipation and worse patient satisfactions as well. Things like rectal intussusception, rectal seal, enteroseals, all these need to be repaired. First, assess the patient outcomes function prior to any colectomy that should be offered to the patients as well. The rectocele repairs causing obstruction, usually rectoceles are felt in a lot of women. And in these cases, usually if they're greater than 4 centimeters and they're symptomatic, then surgery should be offered. And in any woman that sort of gives a history of digital reduction or any sort of splinting that needs to happen to allow defecation is a good indication to repair the rectocele. And the ability and repairing rectoceles can happen in many different forms, and the results are very similar. There's transvaginal repair, transrectal repairs, transsphincteric repair, transperineal repairs, and some surgeons prefer to use mesh and others don't. Me personally, I do transrectal repairs with no mesh, but the outcomes are very similar. There's no sort of definitive, winner in terms of the overall long-term outcomes when it comes to this. The complication rates and outcomes pretty similar between them. So usually what ends up happening is, depending on the surgeon preference that the patient is seeing, would be the repair of choice for repairing the rectoceles. What about for the patients who have either rectal prolapse or rectal intussusception, or they may have rectal intussusception and rectoceles, or sort of multiple components that may be in there? And for this, really recently, the repair that seems to hold true is ventral rectopexy, mesh rectopexy. And a lot of times the MRI defecography will give us the information that we need. And in a lot of these patients, they usually will have global pelvic descent. And these patients are usually discussed at the Multidisciplinary Pelvic Floor Conference, where a lot of times they may have concurrent vaginal descent or bladder descent as well, and may require a concurrent repair with our urogynecologist. But this needs to be addressed before any colectomy can be discussed with patients. And overall, just repairing those will improve the constipation in 80 to 95% of patients, and they don't even require segmental resection for this. The recurrence rate is about 5% overall, and patients with fecal incontinence sometimes also report improvement. And a lot of times this is because with the rectal intussusception or prolapse, usually it keeps the sphincters open and splinted, and as such they have passage leakage of mucus and stool that could be quite bothersome. And as you pull up the rectum out of the pelvis and secure it to the sacrum, you'll have a lot of these symptoms will also resolve and improve the patient satisfaction. So in summary, management for constipation is very complex, and I think it has to be a multidisciplinary approach. Is the only way that we can have the best outcome for the patients. Medical management should be exhausted prior to any surgical intervention, especially if it involves colectomies. And management of patient expectations is of paramount importance. It can't be emphasized enough, especially for the surgeon, because if patients who are on par with you and understand the risks, then you go on a journey with them to get them to a better place so that they understand where they were better, so that they can see that they're having an improvement in their long-term outcome. And obviously address the outlet dysfunction prior to any colectomy. And the best outcome for slow transient constipation is with total abdominal colectomy with ileorectal anastomosis. And that's it for me.
Wonderful. Thank you so much, Dr. Tilahun. That was an incredibly thorough discussion. And from a gastroenterologist point of view, these are not things that we think about very often. So I learned a great deal, and I appreciate that. We do have some great questions that have come through. The first question is about, I think both of you talked a lot about bloating, and so our audience wanted to know about SIBO. At what point do you consider SIBO as a consideration of your constipation versus SIBO as the cause of your bloating versus the constipation? Dr. Aguido.
Yeah. So SIBO is small intestinal bacterial overgrowth, and it's more of a bloating type symptom, the way I look at it. Okay, so when I approach these patients, or I suspect a patient who has SIBO, I first identify whether they have risk factors for SIBO. Okay, because if we talk about constipation, there are numerous causes for constipation. Okay, in patients with SIBO, a lot of times these are your diabetics, these are your patients who've had multiple abdominal surgeries, these may be immunocompromised patients. Okay, these may be patients who have generalized GI dysmotility disorders. Okay, a lot of times these patients would present with bloating, with distension, and when I ask them bloating, I also ask them when does the bloating onset start? Is it usually few minutes, hours after eating? Because a lot of times patients who have SIBO actually have postprandial bloating and distension. Okay, and if they do have the risk factors for SIBO, and then these are the patients that I would evaluate further for SIBO. And how do I evaluate them? There's two approaches I go through. One is I can empirically treat them with Xifaxan, okay, which is a localized antibiotic. It's non-absorbable, okay, and works great for bacterial overgrowth. Or I can also perform a breath test, which may also help me determine whether the patient has hydrogen predominant SIBO versus methane predominant SIBO. Now the difference between this and knowing whether it's hydrogen versus methane predominant is a lot of times patients with hydrogen predominant SIBO usually present with bloating and diarrhea. Unlike patients who have methane predominant SIBO, usually present with bloating and constipation. And the reason is because these methane producing bacteria or methanogens tend to slow the GI or colonic motility. And in these patients, I would probably add another antibiotic such as neomycin on top of the usual or standard antibiotic treatment for SIBO.
Thank you so much. That was great. Dr. Tilahun, at what point in our medical therapy should we discuss that maybe it's time to send someone to a surgeon?
I think, if you're sort of going through the medical management and you're not seeing the results and you're sort of starting the process of sending them for diagnostic studies for slow transit and things like that, and at least if you have one of those studies back, I think it's always a good idea to have them see the surgeon so that we can at least introduce the different topics, let them know that all the possible surgical paths that they may be embarking on if medical management fails. And I think that may allow you a little bit more not want to say cooperative, but patients that are a little bit more eager to sort of exhaust all available medical management. And I think I think we all know that sometimes with constipation, you have patients that are quick to give up on a regimen.
Yeah.
And so, and I think a lot of times once they understand that there isn't sort of like an overnight quick fix to something, they may come back to you a little bit more willing to go through a regimen, or they may be willing to say, you know, Dr. Kashi, this bloating thing's not as bad as I was putting it, you know. That bag thing that surgeon said, that was absolutely terrible. I'm with you all the way. And and you may get a lot better patient satisfaction once they have an idea of what may be coming down the line if we were to pursue surgical management.
Absolutely. So, Dr. Guido, you know, we did talk about medical management of other conditions, and so patients who are on medications for many other diseases that can cause our secondary constipation. What is your approach to those patients for relief of their constipation?
So for patients with secondary conditions, so for example, a patient with neurologic disorders, okay, or patients with diabetes, or patients who have psychological or psychiatric histories, I always try to tailor my management towards their needs. And I also try to set, I think more importantly, whenever I approach patients with any type of medical condition, the treatment for constipation has to be individualized. Because it's not just a set, you know, have everyone be on fiber and laxatives type of situation. These patients are special populations and they have special needs. Okay, so for example, I have a patient with neurologic disorders, okay, a patient with Parkinson's or maybe a spinal cord injury who presents with constipation or bloating, then I always set the expectation first, okay? A lot of times these patients may have underlying a neuropathy, okay, or a myopathy, okay, and they present with bloating. So bloating may be their predominant symptom, and we may have to be more realistic in terms of their expectations, in terms of bowel frequency. A lot of times they'll say, my husband has one bowel movement a day, why do I go once a week? You know, you can't compare apples with oranges, you know.
Right.
Everyone is very different. So I think setting that expectation for these patients is very, very important. Okay?
I agree with you.
Because at the very end, that's, you know, it helps set the goal and guide management.
I think that's absolutely correct. You know, when we talked about these other studies that we can send our patients for constipation, you gave a very nice outline and a paradigm of what to follow. Our audience wants to know, do we really have to go through anal manometry first before we move on to colon transit studies?
Yeah.
Would you recommend that someone can do a colon transit study prior to manometry?
Yeah, so that's a very good question. It's a question I get a lot. And in fact, I also have a lot of patients who come from the community who have colon transit studies without an anorectal manometry. And the reason is because anorectal manometry is not readily available.
Right.
Okay, and the reason the approach is to perform anorectal manometry and assess for defecatory disorders first prior to going through colonic transit testing is because a lot of times patients who have slow transit constipation may also have defecatory disorders. Okay, and studies have shown, multiple studies have shown, is if you treat the defecatory disorder, you manage the defecatory order, when they repeat the colonic transit testing, it eventually normalizes. Okay, and another reason is if we send patients over for colonic testing prior to anorectal manometry, we're already teeing up the patient to eventually undergo surgery. Because a lot of times when these patients who have combined dysynergic defecation and colonic transit issues, a lot of times their colonic transit testing will be abnormal, okay? And then they will fail laxative therapy, and then they will eventually require surgery, okay, at the end. And what you don't want is you have a patient who's had a colectomy and then now ends up having defecatory disorders. Okay, so I think before you actually consider a patient for colonic testing, it's always important to check for defecatory disorders first and addressing that issue first before you go that route for colonic transit.
Sure. Dr. Tillahun, total abdominal colectomy seems to be the preferred surgical route. What about patients with ileostomy? How do you decide which ones will go directly to ileostomy?
So usually, if for the patients who have not very, if there's any hesitation in terms of their overall symptom, or if there's a doubt that the colectomy won't benefit them significantly, I think the loop ileostomy is a great sort of in between temporarily to see if their symptoms improve, because we've all seen patients who have 2 or 3 bowel movements a week, and technically if it's 3 a week and they're doing fine, it's okay, but for them it's not enough and they want to have that daily bowel movement, or there is questionable results in terms of the global motility as well. And in these individuals, especially if there's any slow transit, gastric emptying study is slow, or sort of there is concern for global dysmotility, these would be the great patients to give them a loop ileostomy up front. And that in itself will allow the patient, 1, to know what it's like to live with an ileostomy, and 2, to see if their symptoms improve and their quality of life overall improves at the same time. So, I think any patient that I worry won't do well with a colectomy, then I'll offer them sort of the loop ileostomy as a temporary sort of in between, to allow them to sort of have a relief from their symptoms from their constipation and the symptoms of the constipation that worries them. And then if they do well with the loop ileostomy and they're still happy with it, then we proceed with the additional surgery.
That sounds great. Thank you so much. Well, I hope all of you have enjoyed the discussion as much as I have, and I certainly learned a great deal, and I hope you'll join us for our next session.